Hello.
Thank you. We are ready to begin today's pediatric session. Could you please give our opening remarks?
Yes, Taryn. Well, good afternoon, everyone. I'm Dr. Joseph Donanasi, past Chief of Division of Anatomical Pathology at the Children's Hospital of Eastern Ontario, the CHIO. Co-chair of the Pediatric Oncology Group of Ontario, the POGO's Pathology and Molecular Diagnostics Standardization of Reporting Task Force. The task force is co-chaired by Dr. Gino Somers, Division of Pathology at the Hospital for Sick Children, and Dr. David Malkin, POGO Medical Director, and was initiated in 2012 to frame recommendations to POGO regarding pathology and molecular diagnostic practice in Ontario. On behalf of the Pediatric Oncology Group of Ontario, the Canadian Partnership Against Cancer, and the Canadian Association of Pathologists, I would like to welcome everyone to today's CAP education session on the Pediatric Rhabdomyosarcoma electronic cancer checklist. Before I introduce our speaker and we can get underway, I would like to take care of a few housekeeping items first. One, this session is being recorded, and link to the recording will be circulated to all participants via email when it becomes available. 2, both live presentation and the recorded presentation are eligible for CME credits. Information for obtaining credits can be found in the session notice. Note that CME certificates for each of the CAP checklist education sessions will only be issued for 1 month from the date of this presentation. You can refer to the session notice for the exact deadline date. 3. Please note that everyone's line has been automatically muted for today's presentation. 4. We have a large number of participants today and will not be able to troubleshoot WebEx issues as part of this call. If you are experiencing technical difficulties, please call the WebEx support line. We encourage you to submit questions at any time during the presentation using the chat feature within WebEx. Chat instructions can also be found in the session notice. 5. During the question and answer portion of this presentation, a session moderator will post the submitted questions on your behalf for as long as time permits and in the order in which they appear. In that window, please include the following information: your institution's name, name the individual posing the question, and your question. It's now my pleasure to introduce Dr. Gino Somers. Dr. Somers is currently Division Head of Pathology at the Hospital for Sick Children and Associate Professor in the Department of Laboratory Medicine and Pathobiology at the University of Toronto. He has 20 years experience in pathology and 14 years experience in pediatric pathology. He obtained his medical degree from Monash University in Melbourne, a PhD from the University of Melbourne in molecular biology and pathology. He received his specialty certification in anatomical pathology from the Royal College of Pathologists of Australasia in 2002 and completed a pediatric pathology fellowship at the University of Toronto and the Hospital for Sick Children in 2004. His practice includes diagnostic pathology, autopsy pathology, and research. His research activities began in molecular pathology and include independent grant-funded projects as well as numerous collaborative projects focused on the biology and pathology of pediatric undifferentiated sarcoma, rhabdomyosarcoma, osteosarcoma, and synovial sarcoma. His dependent work led to the first description of a novel Ewing-like sarcoma family in pediatric patients and resulted in the first diagnostic assay for this diagnostically challenging tumor. More recently, his research has focused on the implementation of cutting-edge molecular diagnostics for pediatric cancer, including the development and implementation of nanostring technology, detection of specific fusion transcripts in a range of sarcomas. Now, without further ado, I welcome Dr. Tumours to give today's talk on pediatric rhabdomyosarcoma. Dr. Tumours.
Thanks for those kind words, and thank you to all of you for dialing in today to learn more about the CAP protocol for rhabdomyosarcoma and how to use it in your daily practice. I'd also like to thank the Pediatric Oncology Group of Ontario, Canadian Partnership Against Cancer, and the Canadian Association of Pathologists for giving this opportunity. First, down as disclosure information, I have no financial relationships to disclose, and nor will I be discussing any off-label or investigational use of any materials in this educational presentation. I'll give you a brief background with regards to the pediatric protocols that we've been part of. This is essentially a collaboration between POGO and CPAC to support synoptic reporting in the pediatric oncology community. This is essentially to educate and support just pathologists who work with pediatric cancer specimens, but all of those of you out there that aren't necessarily pathologists, but certainly work in pediatric oncology, and to give you a better understanding of what the pathologist puts in the report and why. This is the third in the series. We've done Wilms tumor, and Dr. Dinanasi did a great presentation on neuroblastoma last year. So it's an ongoing thing, and I'm very appreciative of the opportunity. The objectives today are quite simple. I will review the CAP protocol as it relates to rhabdomyosarcoma and its use by pathologists in pediatric oncology. Protocol that I'll be talking about was posted in February 2011. Most of you might know that there is an update of that protocol that will be posted, I believe, sometime in the summer of this year. Some of you might have seen it during the comment period. What I will do is compare and contrast so get an idea as to what is coming in the summertime, how it is different to the protocol that's currently listed. I mentioned the protocol that's covered is the one that was posted in February 2011, authors listed there, and it's still available on the website, and I still use it in my practice of rhabdomyosarcoma. Also, as I said, we'll give you a sneak peek with the upcoming revision. The authors, Barami, Radzinski, Sabir, and Parham, I must say, have done a fantastic job at improving what was already a very good document, made it more user-friendly. They've actually removed some of the areas that weren't thought to be clinically relevant and added a few more that are clinically relevant. So we'll go into that as we go through the protocol today. Obviously, the tumours we will be talking about today are rhabdomyosarcoma, with a focus on the embryonal and alveolar subtypes. They're obviously the two most common that we see in children and young adults. A third category there includes both the spindle cell and sclerosing subtypes, recently described, and we'll talk a little bit more about those two, how they differ from the classical embryonal and alveolar. As always, you know, in classification systems, there's a category for the other tumours, and I'll mention briefly what those other tumours might be, when to include them in the sort of rhabdomyosarcoma protocol. So what I want to mention is that the protocol covers biopsies to resections. And obviously, depending on what type of specimen you have, will strongly guide you as to how you fill out the protocol, because the information you can provide on a biopsy is different to the information you can provide with a resection. Basically, I'm just summarizing here what I've said. So before I launch into the protocol, I just want to give everybody a brief rundown of rhabdomyosarcoma, and I promise this will not take long, because I'm sure almost all of you out there know this very well. But rhabdomyosarcoma, just so on the same page, tumours showing rhabdomyoblastic differentiation. The majority, 8 or 9 out of 10, will occur in children, and the other 15% or so occur in adults. And generally, the adult rhabdomyosarcomas occur in the decade, so young adults. And it's one of those tumours that sort of crosses the pediatric, adolescent, and young adult spectrum. In children, if we focus on the pediatric group, rhabdomyosarcoma comprises around 8% of all cancers, most common sarcoma, and its 5-year survival rate varies from over 50% to close to 5%. And you know, embryonal rhabdomyosarcoma tends to have a better prognosis than the alveolar rhabdomyosarcoma. Next, please. So the sites that rhabdomyosarcoma tends to involve are, it's sort of evenly distributed, I guess, between head and neck, genitourinary, and extremities, and it really is dependent on the subtype. So embryonal rhabdomyosarcomas, almost half of them will occur in the head and neck, and a good percentage will occur in the genitourinary tract. The alveolar rhabdomyosarcomas tend to occur in the extremities, and they also have age distribution whereby the alveolars are more common in older children, the embryos tend to be more common in younger children. And also rhabdomyosarcoma is a fairly special sort of category in that almost 1 to 40% occur in the paratesticular region of children and young adults. So that's a little bit of background for rhabdomyosarcoma, and gives you, I guess, a context about what we'll be talking about today. I'm going to launch into the protocol, and one of the first things that's mentioned in the protocol is specimen handling. And as always, for pathology, the first priority is given to fixed paraffin embedded, or FFPE, tissue, because as pathologists we rely very heavily on the morphological analysis of tumours to help us subclassify and subcategorize. The second priority is from tissue. So if you receive tissue that's from query rhabdomyosarcoma, always place aside some for paraffin, and then if you can also place some aside for freezing, that will certainly help with ancillary tests. More and more we're finding with the amount of tissue we are given, I think it's a natural progression that the biopsies are less and less invasive now, and what that means is that we get small amounts of tissue to work with. And if you're struggling with looks like a very small amount of tissue to work with, it's always good to remember that if you can do imprints and air dry them, you can use them for fish and put the rest of the core in for paraffin. But not that, even if you just have tissue in paraffin, it is possible to use that embedded tissue for ancillary tests. You can use formalin-fixed paraffin tissue for fish testing, and you can certainly use it for RT-PCR as well. And I think that when the first priority is FFPE, I think that's a good thing to remember, particularly if you're dealing with very small amounts of tissue. I'm going to talk about just briefly how we handle biopsies and resections at sick kids. I think you're not something that will be new to you, but it's just a good reminder on the prioritization, particularly with small biopsies. So we get core biopsies. We always obviously save some for formal fixation. A frozen section, which is the second one there in parentheses, we will do it if the surgeon or the interventional radiologist is concerned about lesional tissue, but we don't like doing it because it tends to sacrifice a lot of tissue. If we do a frozen section on cores, we tend to save that as the frozen piece, and then we can use the rest for whatever we need. If we don't do a frozen section, then we certainly will snap freeze tissue, 200 milligrams being quite generous there. I don't think we reach that very often. And our cytogeneticists and molecular geneticists are very good at getting the most out of small pieces of tissue. We do electron microscopy. If it's available, I think it's worth to remember it only needs small pieces of tissue. And the other two, flow cytometry, maybe if you're thinking lymphomas high on the list, but that often doesn't occur in these circumstances. And genetics can be quite useful too. The 500 milligrams there again, being very optimistic, I think we give them 2 cores at most. The specimen handling obviously is on different things. One of the things that is most important for a resection is margins. And margins to be accurate and for marginal stats to help the treatment team, the specimen really should be submitted intact by the surgeon, and optimally, if the surgeon can come downstairs or upstairs to help orientate the specimen, that is ideal as well. And we have a very good understanding between our department and the surgeons that do these operations, so that they hesitate to come upstairs with the big resection and help us orientate it, and point out margins that they're concerned about, that we either look at then and there by frozen section, or we can focus on once the tissue is fixed in formalin and embedded in paraffin. We obviously, I don't need to do this, but just to emphasize that ink the specimen before you dissect it. Sometimes if you have ureters or vascular margins, we take the margin before we ink it because it tends to disappear after you cover everything in black, blue, or green ink. And differential inking obviously should be performed where possible. We also try, whenever we can, to document the block code on the photo. And I'll just give you an example of what that looks like. So this is a flat bone that was affected by rhabdomyosarcoma. And you can see we've differentially inked each margin there, orange, blue, yellow on the other side, and black was the posterior margin down the bottom of the screen. And if you go to the next slide, you can see we've documented the block code there so that if you do have positive margins, we can pinpoint exactly on the specimen where that lies, and obviously let the surgeon and treatment team know that might some planned treatment or reaction if necessary. Just a little bit about how to handle, or at least my experience in handling biopsies and resection specimens. So let's go to the very first category in the CAP protocol, and that's procedure. And it's fairly straightforward. 2011, you see it listed on the left of the screen. The broad categories were biopsy, excision, amputation, other and not specified. It tied it up a little in 2016 in the upcoming protocol with a little bit more detail under each of the categories, and amputation being pushed under resection together with those other categories there. So it's a little more detailed, but again, it sort of tidied up those categories of procedure there. Next slide shows laterality. Now in 2011, there was a category for, whether this was the right side of the body, the left side, and so on. In 2016, that's been removed. And it's been removed because it's important to note for documentation purposes whether it's for example, left femur versus right femur in regards to the protocol and its impact on prognosis, treatment, etc. It was thought not necessary. So that's been removed from the 2016 protocol. Important. Tumor sites are listed there. Essentially the same for both protocols, with the difference being the addition of bile duct in the 2016 category. And those highlighted in red are the favorable categories. Those highlighted in black are the unfavorable or other subcategories. Small addition of bile duct to the 2016 because that was seen as a favorable sign. Difference in regard to the gross location of the tumor is tumor depth, the soft tissue-based tumors. You can see in 2011 we had the different planes of soft tissue involvement, but in 2016, once again, that's been removed because it was thought, or proven, I should say, not to have clinical significance. Size is still a category that's important. You'll see when we talk about staging, size is one of the categories for one of the staging systems. Stays the same. Great dimension is the minimum criteria, but being pathologists, we tend to measure things in 3 dimensions. So dimensions obviously is not going to be an issue. Now, I go back to that. I'm sure you know this, but in those CAP protocol categories, where you see a little plus means that it's not a required element, although it's recommended. I've come across a few of those things. One of those I've really enjoyed about the new protocol is how they've set up the histologic types here. You can see in 2011 we had 11 different subtypes listed on histologic type. That's been rationalized and reduced now. So in 2016 there are the 6 categories listed there. Embryonal and alveolar will be the vast majority of cases that you see, at least in pediatrics. Cell and sclerosing make up probably 5 to 10% of cases that you might see in children. Ectomoma is a very rare tumor, which I must admit I have not seen come across my desk, but I've certainly seen in slide sets whereby you have gamma cell-like differentiation together with the rhabdomyoblastic differentiation. There are the categories there. Other refers to, for example, a combined rhabdomyosarcoma where you might have embryonal and alveolar type morphologies within the same tumor. And rhabdomyosarcoma NOS refers to those biopsies where you just can't tell. It's either too small, or it's a lot of handling artifact, or there's thermal change, and it's rhabdomyosarcoma, but beyond you really can't tell. That is essentially what I use the rhabdomyosarcoma NOS category. And there's very few cases that would fall into that category, at least at a biopsy at our institution. I think a very good progression of this histologic type, making it a smaller number of categories to fit it into. And as with the protocols, the comments field really help describe and paint a picture of what each of those tends to look like. I'm going through now some of the histology of those different subtypes. This is a lesson in how to diagnose rhabdomyosarcoma, but I think it's important for us to, remind ourselves of what these subtypes look like. This is a pathology talk, and I would feel I was doing my duty if I didn't show you at least some photomicrographs of the tumours we're talking about. So this is a fairly classic example of embryonal rhabdomyosarcoma. You can see in the middle of the screen some rhabdoblasts with the cytoplasm and eccentric nuclei. And the bottom right of the screen, in fact, there's an anaplastic cell. It's sort of a spindle tumour with lots of myxoid background. The sort of biopsy that allows you to come up with the diagnosis in a fairly rapid sort of frame, and immunohistochemistry would certainly help confirm thoughts there. The embryonal rhabdomyosarcoma can also look like this, small round blue cells without much in the way of differentiation. However, there are some areas that show the eccentric nuclei and the pink cytoplasm that give you the clue, but certainly in a tumour like this, immunohistochemistry and ancillary tests are very helpful. And that shows the cross-striations that we look for. It's sort of been supplanted a little by the immunohistochemistry that we do, but certainly it's a time-consuming but oddly satisfying exercise for the pathologist to look for these cross-striations on the H&E field. And once you see them, I think most pathologists, most pediatric pathologists, would feel very happy about calling this a rhabdomyosarcoma and giving at least a preliminary treating clinician. The other thing I wanted to briefly mention was the use of immunohistochemistry. We know that there are rhabdomyoblastic-specific markers that allow us make the diagnosis of rhabdomyosarcoma. Derin being a cytoplasmic marker, it marks those cytoplasmic filaments, and myogenin being a nuclear marker for transcription factors involved in muscle differentiation. And you can see, if we pay attention predominantly to the myogenin, you can see that less than 50% of those cells are positive. And that's a pattern that is quite classical for embryonal rhabdomyosarcoma. It's something that I certainly use before I get the molecular back to, in combination with the morphology, to make me feel more comfortable about calling this embryonal rhabdomyosarcoma rather than the older rhabdomyosarcoma. Next slide shows you another type of embryonal rhabdomyosarcoma, sarcoma botryoides, which really is embryonal rhabdomyosarcoma that occurs with a mucous membrane. And the classical sites for this include the cervix, the vagina, the little ear. It can look like a sort of grapes, thus the name sarcoma botryoides. It has a classical pattern histologically, whereby you can see those malignant cells lining up under the mucosa there, the so-called cambium layer. And the next slide just shows a higher power of that. Sarcoma botryoides is a particular type or pattern of embryonal rhabdomyosarcoma that one should be aware of. We use electron microscopy, showing quite nicely here the thick and thin filaments and very occasional Z bands here and there. So, rhabdomyosarcoma. Alveolar subtype is different in its morphology. It tends to be more nested, more cellular and round cell-like. You can see here that toward the bottom left of the screen, you've got discohesive cells at the center of those nests. You've got big pink cells slightly toward the center of the screen at the bottom that have multiple nuclei that essentially give you the impression that the cell is trying to form myoblasts. And it's, one of the patterns of alveolar rhabdomyosarcoma, and gives you a really good impression, the next slide, of the discohesive nature of alveolar rhabdomyosarcoma, and forming these clefts that you can sometimes, night after a long day, misinterpret as artifact, but they're actually, this is how tumor develops. So alveolar rhabdomyosarcoma on the next slide shows a much more diffuse state, and as I said, for the embryonal, it's in a minority of the cells. In the alveolars, they tend to be much more diffusely positive for myelin, and that's something that we certainly use at SickKids to help us come to a decision as to what subtype this is before we get the molecular back. And the slide is I'm going to show you some of the less common variants. This is probably not the best example of sclerosing, but it gives an idea as to what the sclerosing subtype should look like. Remember, the sclerosing subtype of rhabdomyosarcoma should be almost 80% sclerotic and very sparsely popular with these cells, as you can see here. Other 20% tends to have more embryonal-like morphology. And if you see predominantly this sclerosing pattern, it does give you good reason to put it into the sclerosing category of rhabdomyosarcoma. Next slide shows you, again, a less common category, the spindle cell rhabdomyosarcomas. The spindle rhabdomyosarcomas occur in the genitourinary area, and a very significant percentage occurs in the paratesticular location in children, and they have a very good prognosis. And they should have this vesicular, almost smooth muscle tumor look to them in the majority of the tumor area, or at least 80%, the guidelines say. So the category, or the next area I want to discuss, is anaplasia. Anaplasia in rhabdomyosarcoma is definitely a recognized phenomenon. It's either, if you look at the 2011 and 2016, the categories haven't changed. So it's either focal or diffuse. And the definition of anaplasia, the subject definition of anaplasia is very much the same as what you would use for Wilms tumor, in that the nuclei are hyperchromatic. They're at least 3 times the size of native nuclei, and you see abnormal mitotic figures as well. So it can be defined as focal, with the few scattered anaplastic cells, diffuse, where you see more anaplastic cells throughout the tumor, determinate or cannot be assessed through other views there. And if we move on to the next slide, I just want to show you some pictures of anaplasia here. You can biopsy, there's anaplasia that is essentially throughout much of the biopsy sample, at least on screen. I think biopsy samples, it's difficult to be sure whether we're dealing with focal or diffuse. Certainly in this case, it's in more just a few scattered cells. And next slide shows another example of these anaplastic type nuclei within the within an embryonal rhabdomyosarcoma. One must be careful when assessing anaplasia, because rhabdomyoblasts blasts can be multinucleate, can be hyperchromatic, without meeting the full criteria for anaplasia. So just bear in mind that if you have a rhabdomyoblast, careful when assigning the anaplastic type to that, you have to have all those criteria, as just mentioned, which are the same for Wilms tumor. Those asks and gives us a summary of the significance of anaplasia in rhabdomyosarcoma. It's seen in, sort of between 15% of rhabdomyosarcoma. It can essentially any subtype. It's not just limited to the embryonal rhabdomyosarcomas. Tends to be more common in the favourable sites. That sort of inherently doesn't make sense, but that's what's been found. And it increases with age, so older children tend to have an increased risk of anaplasia in their tumours. As I mentioned, it's the same definition as the Wilms. It does negatively impact survival, but as an independent marker and take out all the other factors, its value as an independent marker is limited. And I believe at this point it does not alter therapy, although that might change with more information and more studies that are currently being performed. The next category is margins, and again, obviously we're not talking about small biopsies here, but resection specimens. And I think that the categories are essentially the same. The indeterminate category has been removed, which I thought was a good idea because I couldn't really see what the difference was between indeterminate and cannot be assessed. So it's just been tidied up a little, and categories are fairly self-explanatory. It's, again, very similar 2016 compared to 2011. Once again, they tidied it so that the no regional lymph nodes sampled category has been removed, and no node submitted or found sort of covers a multitude of different scenarios there. And it's fairly self-explanatory how lymph nodes were sold, how many lymph nodes were involved, and it's said no duplicating terms there at all. Distant metastases, basically we have smaller categories again, or not, I guess, if known or not. This is where I think we need, as pathologists, to collaborate with our radiological and clinical colleagues, because we don't necessarily know if there are distant metastases. And sometimes this category I find challenging to fill out if I don't have all the information. And I used to like the not applicable category, because if I didn't know, I would just say not applicable, information not available or something. So it's still obviously important to stage, and as I said, where possible, talk with your clinical radiologic colleagues to clarify the status of distant mets. So additions that have been put in place, we've gotten to the end of the 2011 criteria for inclusion, when we were reporting a rhabdomyosarcoma. The 2016 protocol has several new categories that I just want to briefly touch upon. The first is the presence of preoperative treatment. This is a required data element at this point in the 2016 category protocol, but it is there, and I think it's important to, and again, this is where communication with clinical colleagues is important. And the categories there, again, are fairly certainly allow us to interpret the specimen in mind. To interpret it in context, we obviously need to know if in any prior treatment. Another addition to the CAP protocol for 2016 is the fusion status. This listed there as either you haven't performed it, you've performed it and it was negative, and you've performed it and it's back as a rearrangement in the FOXA1 gene. This is strongly recommended for alveolar rhabdomyosarcoma. If you see morphologically an alveolar rhabdomyosarcoma, it's very important to document the fusion status. It does have diagnostic implications. There's different methodologies that you can use. The two that are listed in the protocol for 2016 are FISH and RT-PCR. FISH gives you the info that there's a rearrangement, but doesn't give you the partner gene. I don't know whether it's PAX3 or PAX7, the 213 or the 113. PCR obviously gives you the partner gene as well. One of the things that is listed there and is coming out in the literature now is if you do FISH for the FOXA1 rearrangement, you break apart probe, and you show not only rearrangement but amplification of the FOXA1 gene, that is much more common in 13 or the FOXA1 PAX7 translation than it is in the 213. And the suggests that you can use that as a surrogate. But in mind, it's not an all or none. You can get amplification in the PAX3 translocated tumours. It's just not nearly as common. An example, this is a classical rearrangement of the FOXA1 gene in a rhabdomyosarcoma with the 213 rearrangement, but obviously you can't tell that just by looking at the FISH. An example, and I thank Dr. Mary Shago at SickKids for giving me this, of a rearrangement where you can see, I'm not going to point out the features, but you can see lots of green dots and green dots separated from red dots. So this is an example of a rearrangement together with amplification of the FOXA1, which is the probe is the FOXA1 gene. It's from a scientist's point of view, clear this is amplification of rearrangement. This, funnily enough, happened to be the 213, not the 113. So I know you should see it much more commonly in the 113, but there it's not an all or none view of the same rearrangement. Also an addition. So the two additions has been so far, the pre-treatment was again not fusion, and you look for that treatment effect. And treatment effect is either not applicable in that there's no treatment, you didn't see any, or it's present and takes two forms, either tumor necrosis, which means obviously it's necrotic, or it takes the form of therapy-induced differentiation, which it is a cause of concern for the radiologists and the clinicians because the tumor has differentiated and not necessarily reduced in size. And then I'll show you an example of a cytodifferentiated rhabdomyosarcoma. The challenge in these cytodifferentiated rhabdomyosarcomas, particularly if the tumor has infiltrated or is near striated muscle, and I have had a few cases where that's been incredibly challenging. But the trick is to focus on the nuclei here. The nuclei look neoplastic; they do not look reactive or regenerative, and I think that's the term message for cytodifferentiation in rhabdomyosarcoma. My last sort of series of slides is essentially on the staging systems. In both the 2011 and 2016 category protocol, protocols, there are two alternative systems for staging that are listed and described. It's the first one, and I'll show you that. Second one, the site-specific one, is not recommended. Oh, okay. It's optional. It's more optional than the first one. There's both, and neither are required data elements. But I think if you were to use one, you would use this one, the Intergroup Rhabdomyosarcoma study system. It's divided into localized tumor or confined to the site of origin or infiltrating beyond the site of origin, but both being completely resected. Tumors tend to be those with a localized tumor and a gross total resection, but with microscopic residual disease. So you have microscopically positive margins when you look down the microscope, or it's a local extensive tumor with local lymph nodes being positive and tumor totally resected, or 2C would be, again, locally extensive tumor with total resection, but microscopic residual disease and lymph nodes. So group 2 leaves behind a little bit of residual disease either in lymph nodes or as positive margins. Group E, with those tumors where you've received a biopsy. I don't think I've ever grouped or staged a biopsy practice. And 3B would be those resections where they're essentially debulking only. And group 4 are those tumors with distant metastases. The other staging system, modified site size metastasis staging for rhabdomyosarcoma, is the second staging system listed in both protocols. I don't use it very often, but just to summarize its main features, it's a 4-stage system like the first system I described, and the branch points, the decision points are the site, and it's again divided into favourable and unfavourable sites. The tumour, 5 centimetres being the cutoff, whether there's regional lymph node involvement, and whether there's distant metastases. So 4 sort of decisions in which can then categorise the tumour into its appropriate stage. My summary slide. What we've done today is reviewed the existing protocol and, I guess, given some explanation as to what each of the categories in that protocol mean and how to interpret those categories and how best to fit the rhabdomyosarcoma into each of the subcategories. We viewed the upcoming changes for 2016. As I think it's a much user-friendly document and an increased emphasis on molecular changes in the alveolar rhabdomyosarcomas, as well as recognition of related changes and its importance. We've also briefly reviewed the histology and pathology of rhabdomyosarcoma. And last slide is acknowledgements. I'd like to thank the College of American Pathologists authorship list for rhabdomyosarcoma, particularly Dr. Erin Rudzinski, who provided no end of advice to the new protocol and its changes and how it came about. The people at SickKids, Drs. Thorne, Chami, Nan, and Chung, provided me with cases and advice. Mary Shago, our cytogeneticist, helped me with the cytogenetics changes. As always, the folks at PO have been incredibly supportive. David Malkin, Corinne Greenberg, and Nicole. And Shireen here at CPAC helped me with all the technologically related challenges I was having. So thank you.
Thank you Summers for an excellent talk today. So we'll just wait to see if we have any questions for you today, and then I shall read them out. So this question comes from Dr. Elka Miller, and she asks, what is the difference between wide local and radical resection?
I used to ask the surgeons exactly what they mean by both of those terms. In my practice, wide local is somewhat less extensive than radical, but it would vary for each site, and I would be guided by surgeons' take on that. For example, in kidney surgery, radical would involve dysphagia and taking the adrenal gland. A wide local, if we use the example, would be slightly less extensive, maybe not involving the adrenal gland itself, and not involving all those compartments of a radical resection. But I think it would be site-specific, and I would be guided by what the surgeons say.
Dr. Miller has another question. So I guess the favorable and unfavorable sites for our MS.
So that's a good question, and I think it really relies upon studies that have been done looking at the prognosis of these sites and whether there's any difference in survival of these patients. With regard to the sites, the sites listed in red were the favorable sites. They were associated with a better prognosis than those that were not listed in the red. But I can give you specific numbers. It's in the protocol. There are references to that. If you want specific survival rates and so on, you'd be best to go to the literature. I do know that they are associated with a better outcome.
Okay, and I think might be our last question for this session. So other questions, then we'll turn it back to, too soon. So next question comes from Dr. David Malkin, and Dr. Malkin of Togo asks, the advent of nanostring and next generation sequencing technologies and their application to pathologic diagnoses in the context of rhabdo and other tumors, what is the process whereby CAP incorporates these findings? Likely that targets so identified will be of practical value to the pathologist in differentiating.
Let me just read that again, David. So I think that I'll talk about nanostring quickly. That's a for the detection of fusion transcripts, and it allows us to look for multiple fusion transcripts in the one reaction, and that basically is a multiplex PCR type tests. I think that's something I mentioned to CAP, that they had RT-PCR and FISH as the categories for test types for picking up the fusion, but I think with the advent of these more multiplex type assays, there should be an other category to allow us to put that in. With regard to next-gen sequencing, there are a few studies coming out now that are describing point mutations in rhabdomyosarcomas, D1 being a good example of mutations in MyoD1 being associated with clinically actionable type changes. Early days yet, but I think probably in the next few years there's going to be a much better understanding of the genomic landscape, to steal a term from your group, David, a much better understanding of the genomic landscape of rhabdomyosarcoma and which tests are going to be relevant for targeted therapies, particularly we can pick up by next-gen sequencing.
Thank you much, Dr. Summers. And that is our last question. So, Dr. Dhananasi, if you could please give our closing remarks for today's CAP education session.
Yes, thank you, Sherin. Well, on behalf of the Pediatric Oncology Group of Ontario and the Canadian Partnership Against Cancer, as well as the Canadian Association of Pathologists, I'd like to thank Dr. Summers for an excellent presentation today. This is the third pediatric synoptic pathology reporting webinar session since 2004. The first one, also given by Dr. Summers, had focused on Lymph tumor in 2014, and then the second was focusing on neuroblastoma in 2015. And this is also the fifth and final session of the 2016 series of CAP checklist presentations. Just as a reminder, both the live and the recorded presentations are eligible for continuing education credits. The recorded sessions are also archived and are available on the CPAC cancerview.ca website and on the PO educational portal for pediatric sessions. Now, in order to request your certificate of participation, please provide your name and an email address at the link included in the session notice. Here you will also find an optional session evaluation form, which we encourage you to complete. The information collected through the session evaluations then allows us to ensure that these sessions continue to be informative and relevant to your everyday practice. We will appreciate your feedback and suggestions. Please see again the session notice for more information. Now, once the archived WebEx recording of this presentation is ready, it will be made available for wide distribution via links posted by POG and CPAC. Access to this recording will be available for review at your convenience, and it is not restricted. So very much, everybody, for attending.
Thanks. Goodbye.